Good morning, my name is Dr. Cynthia Magro. I'm the Director of Dermatopathology for Weill Cornell Medicine. Welcome to our weekly CPC Interesting Case Conference. So this week's case is that of a 33-month-old girl who was referred by a rheumatologist for rashes on the joints and face. According to the mother, the patient initially had erythematous cheeks, which improved, but was then followed by a rash that started on her ankles in January and spread to her hands, and really involved skin over many of her joints in general. Her outside labs included an ANA of 1 to 640. Her aldolase was normal. Her LDH was actually elevated for her age. She has a twin sister with apparently similar clinical findings. The mother has a history of Hashimoto's thyroiditis and lupus. The father has probable eczema. So this is a picture of the rash that was biopsied. You can see these shiny, flat-topped papules that overlie the interphalangeal joints of the fingers and the metacarpal phalangeal joints. As well, there was evidence of nail fold capillary dilatation, which I don't actually have a photograph of. So a skin biopsy was performed and showed a very striking interface dermatitis that was mediated by lymphocytes. And you can see that the pattern ranges from a very cell-rich or so-called lichenoid pattern to one that is more cell-poor. And this particular photomicrograph really is an excellent depiction showing that hybrid lichenoid cell-rich pattern juxtaposed to areas of cell-poor interface dermatitis. Also noteworthy is the fact that the epidermis is attenuated. So essentially the biopsy showed this atrophying interface dermatitis that ranged from a lichenoid pattern to a cell-poor one. This particular photomicrograph is noteworthy for not only the basilar vacuolar alteration along the dermal epidermal junction, but if you look at the microvessels have evidence of a chronic microvascular injury phenomenon given the corrugated, thickened basement membrane zones, indicative of antecedent episodes of endothelial cell injury that will then be a stimulus for reduplicating the microvascular basement membrane. And in fact, these thickened vessels, which do indicate some element of chronicity to microvascular injury, can be highlighted very nicely by the PAS stain. So this is a PAS with diastase preparation. There really isn't much in the way of abnormalities of the basement membranes under the epidermis. There is a little bit of reduplication over here, but what is particularly impressive is the reduplication of the basement membrane zones of the dermal papillae capillaries, really the vessels within the superficial vascular plexus. Now, there were 2 immunohistochemical stains that I applied to the case, which facilitated making the diagnosis in this case. The MXA stain, or the myxovirus resistance protein A stain, which is the surrogate type 1 interferon marker that we use on paraffin-embedded tissue. And so this photomicrograph is that of the MXA, which is the surrogate type 1 interferon marker, and it is strongly upregulated. You can see that the endothelium is significantly positive along with the inflammatory cells. A blush of staining in the epidermis, but really the dominant staining pattern is the microvasculature and the inflammatory cells. Now, as I was mentioning, the second critical stain that I did in this case is the membranolytic attack complex, or the C5b-9, which actually works extremely well on paraffin-embedded tissue when you use a diaminobenzidine technique. Now, when you're looking at C5b-9, there are a lot of non-specific staining patterns that you have to be aware of, one of which is the granular deposition pattern along the dermal epidermal junction. But in this case, what is really key is the microvascular deposition of C5b-9. So what you're looking at here is a dermal papillae, and in the dermal papillae is a dermal papillae capillary that is highlighted by C5b-9. So, to summarize, we have a lymphocyte-mediated interface dermatitis. There is that dominant lichenoid pattern, but it's really a hybrid morphology, lichenoid to cell pore. We do have chronic microvascular changes that are actually quite characteristic for complement-mediated microvascular injury. So when you have C5b-9 as the effector mechanism of endothelial cell injury and the endothelium is damaged, that reduplication of the basement membrane zone is sequelae, and hence those types of changes really signify complement-mediated vascular injury. And as I was mentioning, the PAS stain really highlights those thickened basement membrane zones. And corroborative of the effector mechanism of this vascular injury being the membranolytic attack complex is the fact that we demonstrated C5b-9 using a diaminobenzidine technique on the paraffin-embedded tissue. Furthermore, we were able to document a very striking upregulation of the type 1 interferon response revealed by the prominent staining pattern for MXA. So the diagnosis in this case is that of pediatric dermatomyositis. Dermatomyositis is among the autoinflammatory myopathy syndromes, which also include polymyositis, sporadic inclusion body myositis, and necrotizing autoimmune myositis. So what are the clinical criteria of dermatomyositis? Well, as would be suggested by the name, many patients, in fact, have discernible muscle weakness. It's usually a symmetrical weakness of limb girdle muscles and neck flexure muscles. A muscle biopsy will show necrosis of type 1 and type 2 fibers, and a vascular reaction that can be inflammatory with perivesicular atrophy. Positive EMG studies. The dermatologic features include the classic heliotrope with periorbital edema, the Gottron's papules, as we saw in our patient. Those flat-topped papules, in fact, were Gottron's papules, and they can occur over the fingers, knees, and elbows, especially in the pediatric age group, and on the ankle. And it should be emphasized that in dermatomyositis, the targeted organs vary from patient to patient. So you can actually have patients who have cutaneous dermatomyositis but actually don't have any evidence of myositis, and we actually call that dermatomyositis sans, or without myositis. So this is a patient with the classic orbital edema and heliotrope, and just like our patient, here we have the typical Gottron's papules, which are these shiny flat-top papules that have this very characteristic joint localization overlying the metacarpophalangeal joints and the interphalangeal joints. And because of the critical role of vascular injury in the pathogenesis of dermatomyositis, seeing nail-fold microvascular abnormalities are also part of the clinical findings. The Shaw sign, where you have this reticulated erythema in the upper back, and again, this simply emphasizes the importance of those hand changes in making the diagnosis. Now, a very interesting feature of pediatric dermatomyositis, which is actually very uncommon, is the localization of the Gottron's papule, or the Gottron's sign, which are more diffuse patches overlying the elbow and knee. So what is the baseline histology of dermatomyositis? Well, the baseline histology, in fact, is an atrophying interface dermatitis, but instead of being this cell-rich lichenoid pattern that we saw in our patient, characteristically in adults, which would define the dominant population, the interface is cell poor. The epidermis is attenuated. It's very characteristic to get this striking, corrugated, thickened epidermal basement membrane zone. But very core to making the diagnosis of dermatomyositis are the microvascular changes. And what are they? Well, they include the alterations that I discussed in our case, basically the base membrane zone thickening, but then there is compensatory vascular ectasia. And because these patients have an inability to repopulate the damaged endothelium, they actually have a deficiency in their endothelial progenitor cell population. Eventually the microvessels actually disappear. So one of the hallmarks of dermatomyositis, over and above the chronic microvascular changes with the thickened base of membrane zones, the vascular ectasia, is the disappearance of blood vessels. So you typically see vascular dropout, and the brunt of all these vascular changes, the acute endothelial cell injury, the chronic microvascular changes, including ectasia and BMZ thickening, and vascular dropout, are concentrated in the superficial vascular plexus. And in more acute lesions, you can actually see mummified necrotic endothelial cells being sloughed into the vascular lumens, leaving behind blood vessels that are largely devoid of endothelium. So here we have a microvessel that really has a mummified eosinophilic appearance. There's no viable endothelium. That's a necrotic endothelial cell that is sloughed into the lumen. And here we can see these microvessels in the superficial corium that are largely stripped of endothelium. And the basis of the endothelial cell injury relates to a Jellincombe's type 2 immune reaction targeting the endothelium. So it's actually mediated by anti-endothelial cell antibodies. And these are just a collage of images that emphasize the superficial vascular dropout, leading to almost a desert-like quality to the dermis. Note the attenuated epidermis, the conspicuous thickened basement membrane zone that has this corrugated appearance, and these microvessels that have strikingly thickened basement membrane zones that almost impart this octopus-like appearance to the vasculature, and really relatively cell poor. Typically, when one deals with complement-mediated endothelial cell injury, the histology is oftentimes remarkably pussy inflammatory. And here is a very striking microvessel. Now this vessel has repopulated the endothelial cells that were damaged, but related to the many episodes of antecedent microvascular injury is the thickening of the basement membrane zone, producing this octopus-like corrugated, thickened basement membrane zone. And as I was mentioning, there is this problem with repopulating the microvessels that have been damaged by endothelial progenitor cells, so the vessels do disappear. And so here we have an attenuated epidermis, very few microvessels. The few present are largely devoid of endothelium. As I was mentioning, the effector mechanism of microvascular injury and dermatomyositis is the membranolytic attack complex. And some years ago, we studied, MAC and C5b-9 deposition patterns in dermatomyositis. And really, when you look at the classic immunofluorescent profile of dermatomyositis, the hallmark is a negative lupus band test with a lot of C5b-9 within microvessels. And so here we have this nice immunofluorescent photograph from our paper on the direct immunofluorescent profile of dermatomyositis. And you can see that non-specific pattern along the dermal epidermal junction, but then note the prominent granular deposits within the microvasculature for C5b-9, indicative of the role of C5b-9 in the pathogenesis of the vascular injury. And not surprisingly, when you look at the muscle biopsies in patients with dermatomyositis, the same type of microangiopathy occurs. Now, although characteristically the anti-endothelial cell antibody vascular pattern is pussy inflammatory, you can also get a lymphocytic vascular reaction. So this case of dermatomyositis, the endomesial vessels, in fact, showed a lymphocytic vasculitis, but the basis is essentially a Jellincombe's type 2 immune reaction targeting the endothelium. Note the prominent deposits of C5b-9 within the endomesial microvessels, reflective of a Jellincombe's type 2 immune reaction. This is just a photomicrograph, actually, of a blood vessel that looks kind of eosinophilic. Why? Because the endothelium is necrotic. When you slough endothelium and you expose type 4 collagen, you activate the clotting pathway, and so this vessel not only exhibits endothelial cell necrosis, but also shows intravascular fibrin deposition. And another characteristic finding in dermatomyositis is the upregulation of interferon expression in the endothelium. This is the MXA stain, showing a very intense staining pattern in the endothelium, and likely the interferon upregulation also contributes to the vascular injury, as I will discuss presently. As I was mentioning, the basis of the C5b-9 deposition in the vessel, which in turn is what basically generates the holes in the cell and leads to cell death, is classic complement pathway activation triggered by antibodies targeting the endothelium. The other two pathways, the mannan-binding lectin pathway and the alternative pathway, are not specifically implicated in dermatomyositis. As for the type 1 interferons, well, they interfere with viral replication. They do enhance the innate and adaptive immune response. Type 1 interferons are an independent activator of the complement pathway. So not only do you have the anti-endothelial cell antibodies, but the interferonopathy component of dermatomyositis may also be a contributing factor to complement pathway activation. And as I was mentioning, the endothelial cell progenitor problem in patients with dermatomyositis may in turn directly link with the enhancement of type 1 interferons, because type 1 interferons in fact inhibit endothelial cell progenitor replenishment. Now, if you actually take a serum sample in a patient with dermatomyositis and you incubate that serum sample with a fluorescinated human anti-IgG and apply it to generic endothelial cells like umbilical vein endothelial cells, you'll actually see positive staining of that generic endothelial cell substrate. We do that assay here. It's called the Anti-Endothelial Cell Antibody Assay, and this is an example of a patient who had that serologic study done where we take their serum, we incubate it with fluorescinated human anti-IgG, apply it to the endothelial cell substrate, and note the very striking granular nuclear staining pattern localized to the endothelium. And this is an indirect immunofluorescent assay compatible with evidence of circulating positive anti-endothelial cell. Now, one of the interesting points of this case was the fact that this case of dermatomyositis was occurring in a very young child. And in pediatric dermatomyositis, there are a few interesting points I just want to briefly address. In adult onset dermatomyositis, of course, there is this association with malignancy, but in the setting of pediatric dermatomyositis, a point I've already alluded to, there probably is an important role for an endothelial tropic viral infection, most commonly parvovirus B19. And over the years, I've done some interesting studies on endothelial tropic viral diseases and the role of these viruses in the pathogenesis of autoimmune disease. Now, the images I showed you in the earlier part of this presentation in terms of classic adult onset dermatomyositis were in the context of this cell-pore atrophying interface dermatitis. In our index case that we presented today, the patient had really a cell-rich lichenoid pattern of interface dermatitis, recognizing that there were those areas of more cell-pore interface change. And in general, my experience has been that in the setting of pediatric dermatomyositis, it is actually not uncommon to see this lymphocyte-rich interface pattern. And who knows why that is the case, but it may relate to the potential role for viruses in the propagation of pediatric dermatomyositis. Sometimes dermatomyositis is induced by drugs, most notably statins and terbinafine. We know in children that a key trigger to dermatomyositis is probably endothelial tropic viral infections, specifically with parvovirus B19. In fact, in this child, she started out with a rash in her cheeks, which might have been acute parvovirus B19 infection. Now, we also know in adults there obviously is a link with malignancy. Dermatomyositis can be a paraneoplastic syndrome. So here we have the potential for molecular mimicry between tumor antigen and antigenic epitopes on endothelial cells. There are a variety of autoantibodies that are what we call myositis-specific autoantibodies. For example, the anti-Immunohistochemical tRNA autoantibodies such as Jo1, PL7, PL12. We also have these antibodies really defining a syndromic complex. So when patients with dermatomyositis have these specific antibodies like Jo1 or OJ or PL12, they will have this condition called the antisynthetase syndrome, where they have interstitial lung disease, which, by the way, reflects those antibodies targeting the septal capillaries, leading to septal capillary dropout and pulmonary fibrosis, the mechanic's hands, Raynaud's phenomenon, fever, and non-erosive arthritis. It's not uncommon in adult dermatomyositis for these antibodies to be present, but they're pretty uncommon in children. The anti-Me2 are these patients will have typical cutaneous findings of dermatomyositis without lung involvement or polyarthritis, and it'll be a negative predictor of paraneoplastic myositis. They typically have poikiloderma, flagellar erythema, and a Shaw sign. Anti-MDA5 dermatomyositis, well, in that dermatomyositis, these patients are oftentimes amyopathic, so they have targeted microvascular injury involving the skin and the lung. And in the skin, the severity of the vascular injury oftentimes does manifest as frank ulceration. And the anti-TIF1 antibodies are a strong marker of malignancy, and then of course the anti-H and GR antibodies would be a sign of dermatomyositis triggered by statin therapy. I'd like to thank Dr. Josh Moe, who helped me with this presentation, and Dr. Karen Chernoff was the pediatric dermatologist who saw the patient and participated in her care and provided us with those very nice clinical images. Thank you very much, and as you know, the PowerPoint presentation is available to download and utilize in any way you like to use it, be it in the context of your own self-study or if you have a presentation to do. Thank you very much.